Awesome. So
Okay.
this patient presented with pelvic pain. So we got this protocol. She was we have a gynecologist who has a high volume practice, endometriosis practice. So we did an endometriosis protocol. So that's the T2, and then this is the T1, and these are the post. And then here's the subtraction. Any thoughts? And then the left adnexus here. So there's this T1 hyperintense adnexal cystic lesion, and it has this kind of heterogeneous look to it on the T2. And so the patient was taken, any guess as to what you think this could be? And this is a subtraction, so there's no internal enhancement. So this turned out to be the ovary. So this is an example of a hemorrhagic infarction of the ovary. Patient had IVF before, and and she had deep infiltrating endometriosis that was kind of covering this area, like the right adnexa broad ligament. And we think both a combination of the IVF treatment as well as the underlying deep infiltrating endometriosis caused this to become chronically torsed and then infarct. So,
oh boy.
Yeah.
Was it any T1 signal? I'm sorry.
This is the T1 here. It's all hemorrhagic.
And this was not for sure endometrioma?
Correct. This was not endometrioma. And torsion to me makes sense because that's why you have, what looks like these follicles, right? I mean, these.
Right. No, makes sense.
I mean, imaging wise, in retrospect, we called it an endometrioma, but then the operative findings show that it was the ovary. And
that is
so,
insane. That is a good case.
Yeah. Okay, I'm going to stop share and then let Jonathan show his case while I pull up my next case.
Nelly, I also have cases.
Can you see this?
Yes.
Perfect. Okay. I know I love that, Nelly. I love that you use Visage too, so you can guide me sometimes. Okay. So you ready?
Yes.
All right. So this is a non-contrast CT abdomen pelvis, and the indication is abdominal pain and weight loss in an 82-year-old gentleman. Contrast shortage, so non-contrast, obviously. So we scroll through. I'm just going to stay in the upper abdomen. You can call out anything that you see that just looks suspicious at all.
Presumably that's just ingested stuff in the stomach. And then there's a bunch of like hyperdense lesions in the kidneys bilaterally.
Yeah. So kidneys were just, I think peritonitis or hemorrhagic cysts, but yeah, like, some of the stuff in the stomach's catching your eye. And it did me too. And just given the history, I was like, this could just be ingested material, but given the patient's like weight loss, consider, endoscopy or fluoroscopic upper GI. So.
Sorry, can you scroll to the sagittal to see if it communicates with the wall or if it's.
Yeah. So we had this weird like thickening up here in the cardia.
The cardiac thing, yeah, I have a hard time. Like we've seen cases G junction cancer,
Exactly.
and then we see that thickening.
Yeah. And then even down here near the antrum pyloric region, it's like, are these just folds? Is it a little contracted? But looking at the sagittal here, it's like, is this some sort of like undermining of a mass in here? So all questionable because, it could just be ingested material. So they got the upper GI and he was fasting apparently overnight. And so he's retaining a lot of food and other ingested stuff in his stomach from the initial image. And then here's the fluoroscopic spot. And there's this rounded structure here at the antral region. And then they put him into the prone RAO. And there's some more like filling defect here. And then turn them a little more, and you have contrast just surrounding this mass here. And so this actually is gastric adenocarcinoma. And then the fundus thing, I guess, was just food.
So the cancer was in the antrum?
Yeah.
I think stomach is really hard, especially
Absolutely.
because many times it usually, it's not usually well distended. So it's hard to distinguish between true thickening versus just decompression.
Exactly. I was shocked. I was expecting it just to be all retained in ingested material and like overcall on my part, but
Well, good job.
stop sharing.
Sorry, do you want to go next or I can go? Either is fine.
I can go. Either way. You want me to go?
Sure.
Okay.
And then, as I had mentioned to Jonathan, if I can alternate, that would be really helpful, so I can load images.
Yeah, sure. All right. So the first two cases, let me show them side by side because they come in two kind of situations. So this is a urogram that we were reading outpatient, and then I'm not going to torch you, but you can see something here caught my eye. See that? Like the wall here looks a little
again, and there's the fat looks kind of dirty too.
Right. So this was unfortunately a urogram, which meant that we didn't have all kinds of sequences that we would necessarily want to get. But if you notice here, we were able to get some sagittal, I think. It was on one of, hold on, let me just get the sagittal. So you can see here that they were like, it's hard, but you can see here right there. The thickened diverticulum with some inflammatory changes surrounding. So this was a incidentally noted diverticulitis.
Patient was asymptomatic?
The patient actually, when we called, had a little bit of pain, but didn't think much of it. This was real. And then again, interestingly, about a week, maybe 2 weeks after this case, you're not going to believe it, but this is another urogram, and we were reading it, and the patient has incidentally this big bladder mass with other urothelial things. And then we noticed this. You can see again, this diverticulum is enlarged, very thick and hyperemic, and notice that there's enhancement of the adjacent fascia. And again, unfortunately, the area that we needed didn't have the T2 fat set, that would cinch the diagnosis. But on the sagittal, you can see that the diverticulum is hyperemic, and there's thickening of the adjacent fascia. So this is another incidentally detected diverticulitis. Can't recall off the top of my head if I've ever called these before incidentally on MR. But now there've been two in the span of 2 weeks, as these cases usually happen. Right, I'll stop sharing so you can get to the next case, Nelly. Is that okay?
Yes, that thickening of the fascia. I think that was like key finding because that's how you distinguish from colon cancer. Because with colon cancer, you don't see that stranding of the fascia from the edema, whereas with diverticulitis, you do.
Right. And in this case, actually, we did catch it on T2, and you can see that the wall is edematous here. You can see that the fascia is also edematous. Pretty cute finding.
Great cases.
Right.
And it always comes in pairs.
I know, right? Isn't that amazing?
So this patient had this finding on chest CT. What would you raise as your differential? Obviously, there's a worrisome lesion in the right lower, and there's probably clustered nodularity around here. So given where we are in Arizona, this region is endemic for cocci, and this was cocci. This came back as cocci. And patient also had this.
Oh, wow. Is that like peritonitis too?
Yes, it is.
No way.
Yeah, way. Yeah. So this is, just something to keep in mind if, you see.
And you biopsied it, yeah?
Yeah, this is proven.
Wow.
Yeah. And we see cocci like on a regular basis here, just because of the region that we live in.
Sorry, I'll take over. Make sure that all the identifying situation is out. Okay, cool. All right, so this is a patient who just had a liver transplant and is presenting with, she's in SICU and she's presenting with a rising lactate. And this is the scan. It's not a diagnostic dilemma, right? So, and it's not an eyesight test. This is the graft, and you can see that there are just multiple large areas of complete non-enhancement within the parenchyma. And these are infarcts, even though the vessels in this patient were completely patent. You can see how much of the liver is actually involved in coronals. You can see that the superior part of the liver is completely gone. The interesting part of this case is that they suspected that patient had elevated lactate, so they were concerned with the graft. So they did an ultrasound, which is read as it was fine. I just want to show you. I'm trying to be careful not to flash anything. Okay, so you can see that this was a liver, and it wasn't called prospectively, but you actually can see that the areas of infarction have different echogenicity, and they really correspond, like all these things, and they really correspond to what we see on CT. But they weren't called. I mean, I wouldn't have called them either, because you kind of think that it's just related to heterogeneity, beam attenuation, but these were all actual infarcts that we see on sono.
What is it from? Is it just like rejection, or I mean, I think it looks like the vessels were patent.
Yeah, it must. A patient also had splenic infarct, although not as big, and then patient also had a right adrenal infarct. Hold on, I'll show you
was it just shock, or was it? I mean, I don't think it was emboli. I mean, or
you can see. Well, it has to be, right. Like that's just something with vascular supply. Because look, all of these things are little infarcts, and the entire right adrenal. Here's the left adrenal, and the right adrenal is like you can kind of sort of get a sense that it was here, but it's gone. So I don't know if it was just ischemia during surgery. That I've never seen this extend from just ischemia during surgery. I would expect that there was some sort of embolic events happening. There's absolutely no issues with the artery. It's completely fine centrally.
Yeah, I see. I mean, not infrequently, these kind of wedge-shaped areas of liver that are probably acute liver injury, but I'm kind of wrapping my head around kind of what leads, what causes that. And I think, you're right. It has to be some kind of like vascular etiology, but yeah, I don't know. Okay, so this patient presented with abdominal pain.
Is there an intussusception?
Yeah. Here's the axial. Adult.
Yeah. So you wonder, is like there an underlying lead point, like a mass, or it's in the right lower quadrant. So then, it's like a Meckel's diverticulum can cause that too sometimes. Let's see what else.
Yeah, exactly. So there's an intussusception here, and if there's a little area of we can like a little enhancing thing that's serving as a lead point. So this was resected and came back as a carcinoid. So this is an example of a carcinoid that led to a small bowel intussusception. And I think it's here because there's like a differential enhancement compared to the rest of the bowel. And I mean, I guess the teaching is, in an adult, like we don't see intussusception in the same way that we see in children, where it could, just in adults, we have to look for the lead point, lipoma or, like other small bowel lesions. And this one was a carcinoid.
All right, my turn.
Yes, if that's okay.
Yep. Let me just, okay. All right, this is a cool case. This is a patient who's super sick. She was transferred from rehab because she missed, what do you call it? She missed dialysis. Her white count cell was like 20,000 something. And so they were looking for source of infection. And, we're reading, and then we get to the bladder and notice bladder is thickened, and then all of a sudden there's this area of non-enhancements. And then if you look at the coronals, it's really striking that, the bladder is thickened, kind of hyperemic, and then there are these regions of complete non-enhancements, and then there's a lot of inflammation around it. And then you can see that there's reactive thickening to the adjacent inflammation. So this is a very apparently uncommon, like I've never seen this before, but this looks like this is a gangrenous cystitis. So it looks just like gangrenous cholecystitis, we just kind of have full thickness, not enhancement. The gangrenous cystitis is super rare because normally patients get, diagnosed and treated way before they get to this stage. We're not sure exactly what happened in that rehab and why she's kind of missed out on care so much. But that's what we think it is.
Wow. And patient was not instrumented, right?
No. So she had surgery on her. She had BKA like about 10 days ago. That's why she was in rehab. She missed the dialysis for a week. There's COVID now. There's very high white count. So, yeah.
Wow.
So I wasn't sure. I'm not sure what they're gonna do about it, other than like with gallbladder you have to take these out, but with bladder. I don't know, like, do they have to repair it? Like, I actually don't know. I couldn't figure out based on the few case reports that we've seen what they can do with it. But hopefully they'll do something productive.
This is a patient who came in with hematuria. So this is a venous. Remember excretory. Oh, arrow sign.
Bladder mass?
Yes, I mean, this is not, it's not, I mean, it's not an eye test.
Yeah.
And for me, what was interesting is the pathology. So this one came back as mucinous and enteric subtype of bladder cancer.
Oh, that's so cool.
Yeah, and it's very rare, and unlike it's an adenocarcinoma, you know, conventional bladder cancer is transitional, but this one is adenocarcinoma. And when we think adenocarcinoma, we think about a urachal, like urachal origin bladder cancer or adenomyosis, but this is distinct from urachal. And at the time of diagnosis, about a third will have lymph node mets, and they're usually solitary, unlike urothelial, which is typically multifocal. And they're usually at the trigone or posterior bladder wall, like this case is, but I mean, it can also be anywhere. And they can be papillary or sessile or ulcerating. So then I didn't know, but there are several subtypes of primary bladder adenocarcinoma. So this is primary bladder adenocarcinoma that had enteric histology, but there's also like signet ring and there's mucinous variants as well. I mean, this patient didn't have it, but patients who've have bladder exstrophy, you know, that had a subsequent bladder augmentation are at risk for these types of cancers. And also like a small percentage of patients with bladder schistosomiasis can also get adenocarcinoma. And I mean, in retrospect, you know, when I look at those images, it, unlike TCC, like it has kind of, I can see how it could be, you know, the density is just, it looks different. Kind of hypo, and then it looks kind of heterogeneous. Whereas the bladder cancers that I've seen, if there's wall, then it's wall thickening and enhancement, but then or papillary. This one has an interesting growth to it. Anyways, I don't think we can call it prospectively ever. Do you have any more cases, Victoria?
No, I'm done for today. Sorry.
Okay, I have another case. It's loading. This patient, you know, I'm always amazed by what our interventional gastroenterologists can do. So this patient had a Roux-en-Y gastric bypass, liver transplant, and had like ischemic biliary ischemia, cholangiopathy. So they needed to access the biliary system, but because of the altered anatomy from the Roux-en-Y gastric bypass, they, you know, I've seen them come up with like creative ways to access the biliary system. Like I've seen one case where they, you know, reconnect to the excluded stomach, but in this case, what they ended up doing was putting a stent across and into the stomach, the excluded stomach, percutaneously, to then access the biliary system. it was neat. I hadn't seen this type of access in the past, and I'm not surprised. Our GI gastroenterologists are amazing at coming up with creative ways to make this happen. Okay, I
Nelly,
think.
do you know why
Yes?
they go through the liver?
Oh, why didn't they go through the liver? Oh, that's a great question. I don't know. The patient is fresh post-op. I don't know if that prevents that. I'm not sure. I'm not sure why we didn't go through the liver. Is that the first line? I mean, if they have altered anatomy?
I'm not sure. I just thought that if it's a biliary problem, they could do a PTC and try and fix it. So
Yeah, that's a good point. I'm not sure. I can reach out to our GI and figure out what the thought process is like. When do you go percutaneously transhepatic versus this way for ischemic cholangiopathy?
I mean, I'm sure there is a good reason why they did that, but
Mm-hmm.
Somehow I lost you.
Okay, let me, yeah,
Now I see. Yep.
perfect. And you can see the diagnosis as well, I guess. But I was just trying to wait till we were waiting for you, I was trying to show a couple cases. But this was interesting because I came across this in the community. She came in with left breast lump, and on mammogram, they saw something weird. And so she had a chest CT previously, but interestingly, on the chest CT, this was reported as a questionable soft tissue mass, but clearly, as you can see here, this is retained gauze and a gossipiboma. And she had had a remote history. I know she had had a remote history of breast augmentation. So clearly, but then, this is like a large soft tissue component in association with this. So when I read this out, I was debating, is this like a red herring? Is there truly a soft tissue mass in addition to the gossipiboma? But they excised it, and this was completely fibrous tissue, hardened fibrous tissue surrounding that retained gauze, presenting like a hard breast lump, progressively enlarging in size. So good for her,
I have a quick question about this. How many months or years after the breast augmentation was this imaging?
She presented with this. This was 8 years.
8
Steve.
years after.
8
Okay.
years. Yeah. 8 years. And, she had been noticing that lump enlarging gradually in size. I don't know how much, was it too large to palpation? I'm not sure because I didn't see the patient myself, but she could definitely palpate it as a hard lump by the time it was this size. Okay, so let me share again, and I'll bring up another simple one. More for kind of trainee level. This was like an incidental finding on a staging CT for urothelial carcinoma. And I just thought this was the largest adrenal hemangioma I've ever seen so far. And there's another case that keeps circulating. They had bilateral adrenal adenoma, hemangiomas. So just a cute show and tell, large right adrenal hemangioma. And then I can pull up a couple more.
Just crush everything.
Absolutely.
So you either pause
I'll
or
pause recording. Yeah, no worries.
So do you want me to go? This is a crazy case.
I'll show you this last one, and then
Okay, sounds good.
Pause. So just a cute show and tell, another one of splenogonadal fusion, which is fusion between the spleen and a gonad or mesonephric duct derivative. And, it's basically seen like a Rapunzel's tail, a long soft tissue extending from the spleen down into the pelvis. And it can happen either in males or females. And then there are two types that are described, continuous or discontinuous, and just awareness of this entity and no predisposition to malignancy, just a benign entity. I thought this was kind of a cute cape and a long braid, if you will. So, all right, I'm going to stop as well as pause. Yeah.
So I apologize for slowness because again, I'm sort of on a. Anyway, okay, so this is an interesting case. She's a 27-year-old woman from somewhere outside of the United States who the question comes in is that she has the question was she has some sort of uterine anomaly. They did a laparoscopy and they saw 2 horns. And so they're thinking this is a unicornuate, and their question is it unicornuate with the cavity communicating or not? So this is the initial history we get. And here we go, we're coming down. No, we have pretty ovary. She's young, she's like 24, 20, somewhere in her mid to early 20s. So you can see now we have 2 pretty, what looks like horns. And as we come down, we clearly see 2 cervices. And we can see that the 2 cervices are not connected to each other. They're probably like a fibrous band, maybe even superior vaginal duplication. And then we come down and then we have something here posteriorly that's kind of looks weird. So we opened this case and my first thing was like, oh, this is a very adorable case of didelphys. Clearly we see 2 cervices, so it's not a unicornuate. We see 2 cervices with 2 horns. There's absolutely here the 2 cervices here. You can see that there's absolutely no communication between the cavities at any level, which would differentiate full didelphys from bicornuate, bicallus. So there is this weird kind of cystic structure posteriorly, which we're trying to figure out what it is, and could not come up with anything better than some sort of weird Müllerian anomaly or Gardner duct cyst, although this is not a perfect location for it, but that's what we're thinking. We're about to close the case, and we had actually a urology resident who came in to talk about this case because she was seeing urologist because she's missing a kidney. We don't have any images that proves it, but some by history she's missing a kidney. So as we walk down, almost done with the case, and they say, you know what, her urethra really looks funny right here. So you can see that this is really not a normal urethra. Urethra kind of lost its normal definition. Let's see, here's the non-oblique T2. You can see that this is not, we don't have that nice normal urethral where you see a rounded target-like appearance of urethra where, there's a, nice band of T2 hypointensity where the muscle is supposed to be. So something is happening to her urethra. I'll come back and look at the sagittal. Again, you see that there's something funny happening here. Zoom in here. You can see that the posterior wall of the urethra is just not defined. You can see that the wall, what should be a nice separate space between the vagina and posterior urethra is just completely gone. And it really looks like a sinus where urethra and the vagina or vaginal vestibule come together. So the cool part of this case is that the urology resident said, well, she doesn't have really incontinence. And it's true, she shouldn't have incontinence, right? Because if this is true sinus, then she should be continent because her superior aspect of urethral, sphincter is preserved. And, when somebody, is urinating, it's going to be hard to determine whether any of the urine comes out from vaginal vestibule. So, and this is that cluster of cystic structures. By the report, when they try to do vaginal exam, it was very difficult and they weren't sure if there's one vagina, if there's a vaginal septum. Unfortunately, we're still not sure about that because we just don't have we did not put the gel into vagina. Anyway, so the cool part about this case is that we actually got follow-up from the nice urology resident who took time to actually write us a very detailed description. So the patient does have, she is continent, but she does report chronic history of postvoidal dribbling. which makes sense if she has a sinus. Based on her physical examination, she does not have a normal urethral meatus, and it does look like there's some sort of connection. So the distal urethra communicates with the distal vaginal vestibule, and she does have severe dyspareunia. So they're going to probably do like a high resolution assessment of the area so we can get a better idea. But that's what it sounds like. And we looked up and this urethrovaginal sinus is very rare, but it can be associated with other uterine anomalies, including this cool thing. So that's my first cool case.
Oh my God, super cool, Victoria.
Right?
Yeah, was the vagina single or separated as well?
So we can't tell. I can't tell that. So this is the superior vagina.
Mm-hmm.
We can see that this cluster of cysts seems to be in the wall, not, so it's unclear. Unfortunately, we didn't put ideally for this case, if we knew up front what we were looking for, we would have put a gel, vaginal gel, descend vagina, and just be able to see that. That was not the case. So hopefully the plan is for them to send her back and do like a specialized protocol, do high res 3D T2 of the area, and then descend vagina with the gel so we can see the details of what's happening. So that was my first cool case. I can bring up the next case, or if somebody else wants to go while I bring it up.
Yeah, I'm going to pause.
This was an incidental finding. It was the liver lesion here this was actually a patient that was getting MRI enterography, but the MRI enterography for Crohn's was not particularly interesting, but I was kind of interested in the liver lesion, which here it is on the post-contrast T1 with VATSAT. And I think that's the best look you get at it, maybe. There's a coronal version of it here. Kind of looks like it's got enhancement around the periphery a little bit, then the center doesn't really ever enhance. This was on this image, which is more recent. That's diffusion, I think, which didn't really show any restricted diffusion. Here's T2, T2 bright, basically. I want to try to find there's another T2 here. There's a T2 where little busy inside, but T2 bright, basically. And then it kind of looks like that on an earlier. But the interesting thing about this is, old films are always your friend. And I'm thinking, well, it's probably something benign. Let me look back to see what this thing was. So I'm going to go back to, let's see, this is 15, no. Yeah, about 15 years earlier. Whoops, wrong one. About 15 years earlier. And I gotta get the abdomen. Oh, nope, not that one. I got to go earlier than that. How about 10 years earlier than that?
10 years is good follow-up.
Now it's a little bit more stereotypical, if you will.
Nice.
So that's actually, this is 16 years earlier than this one. So, well, sometimes we see these things that we think are sclerosing hemangiomas, but we don't have the old imaging to be sure. This was one where we have the old imaging so that we can be sure.
Very nice. I was wondering if you were going down the ciliated foregut duplication system.
No, yeah, those are also in this location just about too, but no, I don't think this is one of those. I think this is a hemangioma that is sort of involuting or sclerosing and turning into something a little bit different looking that can mimic maybe a targetoid lesion that you would worry about. But there was enough benign features about it on the more recent one that I wasn't that concerned. But I was happy to have the remote imaging that showed it as a sort of more stereotypical hemangioma.
Indeed, thank you.
Okay, I'm ready.
Okay, should I pause momentarily?
Yeah, just all right. So this is a cool MR case. Okay, so this is kind of, now I've seen something similar like this a couple of times, but not to this extent. So of course not. Okay, here we go. So I guess this is like a good level. All right, so I'll tell you the if you calculate the fat fraction, it's not that bad. What do you think? Anybody sees anything odd in this liver? All right, I'll just talk. So you can see, first of all, like visually, this liver is super duper bright in phase, which is quite unusual. Just like visually, it looks way brighter than it should be. When you compare the signal drop between it goes from being brighter than the spleen to being like ISO to the spleen. So obviously, we all have seen visual drop that looked way worse. But check this out. We have India ink artifact.
Yeah, the India ink kind of threw me.
Well, right. So we have India ink artifact at the junction of parenchyma and the vessels. And we have no India ink artifact at the junction of parenchyma and the fat. So this is probably the worst steatosis I've ever seen. I have seen a few cases where steatosis was so severe that we saw the India ink artifact at the junction of vessels and the liver, but I've never seen the India ink artifact completely disappear at the junction of fat and liver.
There isn't a fat water interface at the liver. It's
correct.
Correct.
Fat. So exactly. So that's exactly what it is. The liver is so fatty that as far as MR is concerned, and here it is on and you can see that this is there. It is on scene. So this is a extreme steatosis.
World's fattiest liver.
Right. So actually, if we were to estimate fat fraction here, it would be very misleading, because like the highest fat fraction you can get is 50%, right? So that's right. So once you have more fat than water in each voxel,
Blow the calculation.
Right. So the fat fraction is actually going to go down. So this is, but it's like going to go down to the other side. Anyway, so this was like a really I've never seen this degree of steatosis. And this is on non-contrast, so it's pretty darn bad. Okay, so I stop sharing while I bring up the next case, right?
Yes.
All right, so this is an interesting case of a patient who came in with shortness of breath. And you can see that she has pretty darn prominent piece. No prior history, as far as I understand. And we'll go down. She's obviously having a hard time breathing because she has this big piece. Notice that she has liver cirrhotic, unknown to her. And you notice that posteriorly she has something in her liver, and this abnormal signal extends superiorly up through the hepatic vein, and then you have something in the heart. So just with this, kind of, we're going to start thinking about, tumor in vein. And this is her post-GAD. You can see lobulated enhancing mass, which is in contiguity with this mass in the right hepatic vein, coming down, and then in contiguity with this big parenchymal mass. So this is a incredibly sad case. She's not, she's in her 60s, I believe, or 50s. No, she did not know that she has cirrhosis. There was some history of alcohol use, but that's how she presented with a humongous, this is the HCC, and then you have this just tremendous tumor in vein, which got into the right atrium, and then she presents with P's, and you can actually see P in the mark right here.
That's like the largest tumor in right atrium I've seen.
It's one of the largest ones, and I've seen. And then the interesting conversation was, how to, what to offer to her, because again, she was, before she had this P, she was absolutely functional, happy, healthy woman. And I've seen case like this with renal cell, where the tumor in vein just traveled up through the IVC into the hepatic, into the right atrium, and they've successfully removed the kidney and tumor and block, and took everything out. So I asked if that is something that they could possibly do here. Mm-hmm. And they decided that it wasn't going to, this is just going to be such a morbid operation that they're not going to probably prolong her life with this. Mm-hmm. So that was that. All right, I'm going to bring up the next case, unless, if anybody else has anything, then go. Otherwise.
Does anyone else have anything to share? Well, Victoria brings up.
Searching for another one, but I'm not there yet.
Okay.
Okay, so I'm almost done bringing up the next case. Just make sure that we have what indication. I don't remember what the indication was, but she's a young woman. She's in her 30s, and I forget, something with ovaries. And notice as we go through. Okay, so I don't think I can window well, but oh yeah. It was the ultrasound on the ultrasound there was this para-ovarian lesion that they were concerned about, and that's why we're doing this MRI. So you can see that the left ovary. She had left oophorectomy, if I remember correctly. So she only has one ovary. You can see that the parenchyma looks pretty good, but then you have this very weird looking, what do you call it? Like black lines surrounding the ovary. And you can see that, however you rotate it, it's encasing the ovary. We see it on all sequences. So on all T208 sequences, it's real. It doesn't bloom on the in-out-of-phase images. So you can see that, with the out-of-phase, with the long echo, you can see that there's really no blooming. So it's not some sort of weird iron deposition. You can see that. And then enhancement pattern was relatively preserved. So any thoughts?
Can you get like a T2 dark cortical rim sign in PCOS? There is described like a rim sign, cortical rim sign or something like that. I remember vaguely, but I may be making this up.
I don't think it would be with. I know that they get centrally the parenchyma can look weird, but not like that. So this is called the black garland sign, and this is black garland sign, and it's ovarian fibromatosis. So I think this is the second case I've seen like this, and I don't know if what significance it carries. I don't think it carries much clinical significance, but it's a very distinct appearance. This we ended up calling just like a little fibrous band with, what do you call it? God, I'm blanking on the name. Peritoneal occlusions, sorry.
Oh, okay. The black garland is quite a befitting name, though.
Yes, so that's what it's called, the black garland sign.
Pathologically, this is fibrous tissue?
Yeah, it's ovarian fibromatosis.
Okay. I mean, I would have searched for fibrous encapsulation of an ovary and see what came up, but I wouldn't have suspected it was black garland sign, no.
Right, but if you search for, which is how first time I saw this is how I searched like fibrous encapsulation of ovary, and this is ovarian fibromatosis, and this particular thing is called black garland sign.
Nice.
Cool.
Okay, let's see.
Colorectal cancer. It's just a routine workup for colorectal cancer metastases, and we came across these adrenal glands. You'll notice that there's multiple focal calcifications in both adrenal glands. And when you see this around here, especially because there's a genetic founder mutation that's common in the Southwest, this is an association with cerebral cavernous malformations of the brain, which cause little bleeding. CCM in the brain is typical, and I'll show you. I got to get to the right here, the MR sequence that's sort of heme sensitive, and you'll notice that all of these little blooming artifacts everywhere you look, and those are evidence of cerebral cavernous malformations of the brain. So this is CCM, and we wrote this up as a paper. It actually appeared in Radiographics maybe 5 to 7 years ago. Published a bunch of cases of cerebral cavernous malformations, and the fact that these calcifications in the adrenal glands are associated with that. I don't have any pathologic proof that there's cerebral malformations of some sort in the adrenal glands, but this proved or helped prove that this is a multi-system disorder and not just a brain disorder.
Super
So
cool.
Go ahead, ask questions.
Steve, do we know if they induce seizures or are a focus of seizures or just incidental?
Yeah, the patients can have seizures and they can have life-threatening hemorrhages.
Hemorrhages,
And
I
so,
see.
and so we have on occasion basically diagnosed the patients with the disorder by noticing the characteristic adrenal calcifications.
Nice. Cool.
Oh, Steve, I'm so happy that you brought up this case because my case is going to be sort of a companion.
Okay.
But go chemical shift sequence. Should I repeat what I was saying?
No, that's good.
For the recording. Okay, so again, we have adrenals which retain the shape, but then on the long echo chemical shift sequence, which in this case is the in phase, you can see that there's tremendous loss of signal compared to the shorter echo, which
black
means
garland sign in the adrenals.
well, unlike the black garland sign in the adrenals, right? The black garland is related to fibrous tissue. So
yeah,
even
no, I'm kidding. Yeah.
No, right. No, but it's an important thing, right? Because the fibrous tissue doesn't cause susceptibility artifact because it's not paramagnetic substance.
Right.
But here we're dealing with deposition of something that indeed is very paramagnetic, and causes loss of signal. So unlike Steve's case, if we look at the CT that was done pretty much at the same time, there are no calcifications. So this is a patient with some sort of iron deposition into his, I don't remember, his or her, into the adrenals. And then, so it indicates so at some point there was some sort of hemorrhage into the adrenals. Yeah, and I remember. So the patient presented with like this tremendous perinephric hematoma, and they were looking to see if there was an underlying mass that was bleeding. We thought that maybe there's a ruptured cyst that bled. Okay, cool. All right, you want to pause for a second while I switch the patients?
Yes.
So this is a young patient that came in with history was unclear, no really prior history, some sort of abdominal pain, blood, inflammatory bowel disease. So the fellow calls me and he says, well, have you ever seen appendicitis on like random MRE? And so, well, to be honest, no, not like I've seen obviously appendicitis on MRI, but not appendicitis incidentally found on MRI elastography, enterography. So the resident is all proud and he says, well, look, clearly there's appendicitis. You can see the appendix is quite thickened. TI is normal, absolutely nothing in the TI. And you can see, it's kind of thickened, kind of weird intermediate signal intensity. Here's the axial fiesta, which is our T2 substitute for these patients. Oh, sorry, this one. So again, we see kind of TI, you can see TI is quite normal. There's really nothing in TI. You can see this appendix is thickened and has kind of weird appearance. So, the resident was very excited about this case. As was I, because I didn't think this was appendicitis. Here it is on the enhancement. You can see that,
it's pretty high.
It's so the interesting parts, and the reason why I think I'm correct in my thinking is that the fat is very, very clean, and the appendicitis, MR is very sensitive for detection of fluid within the appendix, to the point where if you see appendix which is fluid filled on the MR, that's kind of a red flag for appendicitis. But there's no really fluid in this lumen. The lumen is just filled with inflammatory process. But despite like this marked inflammation of the appendix, really nothing much happening around it. But I want to draw your attention to the little calm sign that's happening around this appendix. So, and the patient is not acutely ill. He just has like this chronic crampy pain, which is why they were thinking Crohn's disease. So this, I believe, is a isolated appendiceal Crohn's. And it can happen. It doesn't happen a lot. It happens in a very minority of patients, like close to 1%. But it can happen. And interestingly, it does happen in younger male more often than, there's like this guy is a young dude. Don't remember exactly the name. We thought maybe there's also some rectal situation happening there, but you can see it here. Probably he also has involvement of his rectum as well. So it's not truly an isolated Crohn's, I guess, because he does have another place that's involved. But, that was pretty cool.
Super cool. Yeah.
All right.
Did they do surgical excision or something like that, or we don't know?
No, so we talked to them, and he really has no concern for acute appendicitis. So I think that they're just treating this as a active Crohn's. And Crohn's can really involve any piece of bowel.
Right.
I remember from my very trusted GI attending, she would say, from the mouth until the anus, any place can be involved by Crohn's. So.
Agreed.
All right, you want to pause for a second?
Will do.
Okay, you can start. So I don't remember why the patient was done. It's possible that he was done. Inpatient, and we're reading the case, and Can you see it? Let's see. Okay, there you go. So, patient I've had some sort of cancer. I forget what it was. Oh, your TCC. This was a just tremendous TCC. Like in and of itself, this is an insane case because look at the amount of TCC.
A lot of urothelial cancer there.
Yeah.
Right.
Whole
So yeah, and you can actually see like this is like you can see the entire urothelium
Collecting structures and the
right.
ureter,
It just started, and you can
bladder.
yeah. So he has this just horrible TCC, and he was inpatient. You can see this is TCC just broken off from its where it's supposed to be, and here's another one, and then you go into the bladder, and you have these big things. Okay, so we're reading the case, and you can see these just beautiful, just demonstration of how TCC grows in the bladder. So just in and of itself, this was a cool case. All right, so we're reading the case, and and then I'm like, okay, well, here we go. We have a hernia with some sort of bowel, and I'm like, wait a second, I don't understand how this bowel connects to itself. So here's the sigmoid, goes up, and then we have this weird loop of what's happening. So whenever I see like when I start what's up, then let's figure out what's happening. And let me just bring this. Oh, okay, I can't do that. Let me show that. Can you see the bottom? So you can see that there's this, what looks like a loop, except for it's really not a loop, right? There's something that connecting to sigmoid comes down and then forms this thing, and it's like has air and fluids. It totally looks like a loop.
Is it like a Richter's, or it's just a giant diverticulum inside the hernia?
I think, and an interesting part is this is the patient's CT from 4 weeks before, and noticed that he had hernia, but nothing was inside. And at that time, he had diverticulitis and hernia on the other side.
Wondering if it's an abscess.
So it's a very strange abscess that kind of extended into the hernia sac. I'll show you the sagittal, which is probably the most convincing. No, wait, I have to figure out the correct phase.
You know how eponyms, we'll have to call this the Chernyak hernia, I think.
Look at this. Look at that. This is look at that, right?
You have a diverticular abscess in your hernia.
Yeah. How cool is this? This is a diverticular abscess. So this is, I agree, Steve. This is like it's like on its way to forming a giant diverticulum, right, which in and of itself is a pretty cool finding. But this is like a peridiverticular abscess just kind of drooping down into the steer shape and extending into the hernia. Anyway, so I thought it was pretty cool finding.
The wall is very deceptive here, right, Victoria? I mean, the wall enhances just like the bowel wall. So
yeah. So it's very it's very easy. Like, and again, initially, I think again, I'm not trying to say that the residents are bad. Our residents are fantastic, but this is a tough case, right? And if you're reading it quickly, you're gonna just call it a herniated bowel, and look, I mean, this is the herniated bowel on the other side. Looks very, very similar, but here you can see follow the bowel loop in, and follow the bowel loop out. But in this case, on the other side, on the side that we think, even though it does look similar, right? It's not quite the same because
it's not a loop technically. It's just an elongated blind structure.
Well, here again, we see two loops coming in, then kind of forming a loopy loop and coming out. Here we don't. We see a one kind of neck coming down, and again, like if you kind of reading quickly, or if you're not but, you know, it's not an easy case. So anyway, so it was an interesting.
Fantastic.
It was
attention
interesting.
to detail.
And then look at these huge like TCCs. I mean, we don't get to see TCCs like this, thank God. But you can actually, I think this case also illustrates very nicely what TCC look like when, you know, earlier they're like these hyper enhancing masses. And look at that. This is probably the most extensive TCC that I've seen involving the ureter. Anyway, so we actually think that patient is on immunotherapy. So we think that maybe it's even not quite diverticulitis, it's immunotherapy-related colitis. However it is, it's just a very interesting appearance of a perforated abscess, contained abscess that just kind of drooped down into the hernia sac.
Yeah. Fantastic attention to detail. Absolutely fantastic. Because very tough. Like you said, when you're scrolling through quickly, it just looks like a regular hernia with a loop of bowel.
Yeah. All right, Steve, you can